Hello, everyone, and thank you for joining today's webcast about the new psoriatic arthritis treatment guidelines. My name is Bev Bromfield, and I will be your moderator for today's presentation. Before we start, I'd like to go over a few items so you know how to participate in today's event. We've taken a screenshot of the attendee interface. You should see something that looks like this on your computer desktop in the upper right corner. You've joined this presentation using your computer speaker system by default. This means if you hear music through your computer, you should be able to hear the presentation. If you prefer to join over the telephone, select Use Telephone in the audio pane, and the dial-in information will be displayed. You'll have the opportunity to submit questions to today's presenter by typing in the question pane of the control panel indicated by the arrow on your screen. You can send in your questions at any time during the presentation. We'll collect these and address as many as possible at the end. Before I provide information about the foundation, I'd like to thank our sponsors, AbbVie and Amgen, for helping to make today's presentation possible. Their support on behalf of the new Psoriatic Arthritis Treatment Guidelines webinar is sincerely appreciated. Since some of you may be new to the foundation, here's a little background about who we are, our mission, and what we do. In 2014, the National Psoriasis Foundation developed a strategic plan which drives everything we do as an organization. To achieve our mission and what we do, we identified the following goals: accelerate discovery to cure psoriatic disease, improve health outcomes, achieve goals to help reach our mission, whether it's being involved with an event or becoming a volunteer. By attending today's program, you've already taken a step towards expanding your knowledge about psoriasis and psoriatic arthritis, and to have a better understanding of what it means to live with psoriatic disease. If you have the disease, you can help accelerate efforts towards a cure and greater understanding by participating in the NPF Corona National Psoriasis Patient Registry, which is the largest independent observational registry of psoriasis patients in the U.S. This registry represents a network of dermatology clinics that collect and study patient health information, allowing researchers to compare the safety and efficacy of psoriasis treatments, better understand conditions that are related to psoriasis, and explore the history of the disease. You can also share your experience with researchers about what it means to live with psoriasis and psoriatic arthritis by participating in Citizen Scientist. Answer questions and view your data along with over 4,000 participants. Data is used to help researchers gain a better understanding of the disease. To learn more and participate, visit the websites listed on the screen. We continue to improve health outcomes through our Patient Navigation Center, the world's first personalized support center for people impacted by psoriatic disease. The Foundation's Patient Navigation Center is available to help you find physicians, treatment information, navigating insurance issues, access support through our one-to-one program, and more. Contact us at 1-800-723-9166 or visit psoriasis.org/navigation center. To achieve the Foundation's goals as mentioned, please support our mission through donations or by participating in local Team NPF events near you. You can learn more at psoriasis.org/donate or teamnpf.org. On behalf of the National Psoriasis Foundation, thank you for attending today's webinar to learn more about the key points and evidence that guided the development of the new psoriatic arthritis treatment guidelines, how the new guidelines impact the management of psoriatic arthritis, and recommendations on treat to target, resources to help gain a better understanding of psoriatic arthritis. Now I'd like to introduce you to our speaker, Dr. Alexis Ogdie. Dr. Ogdie is a rheumatologist with the Psoriatic Arthritis Clinic at the University of Pennsylvania Health System. She is also an assistant professor of medicine at the Hospital of the University of Pennsylvania and an assistant professor of epidemiology and biostatistics and epidemiology. Dr. Ogdie is one of the leading authors of the new psoriatic arthritis treatment guidelines. It is my pleasure to welcome Dr. Ogdie, who will present key highlights and what the guidelines mean to your treatment of psoriatic arthritis. So I'll now turn it over to Dr. Ogdie.
Thanks so much. Thanks for the introduction. So these are my disclosures. I have consulted for a variety of different pharmaceutical companies and have received grants for research funding to these to either Penn or to Forward, the National Data Bank for Rheumatic Diseases, and royalties to my husband. So I also did serve on the executive committee for the development of these guidelines, but just kind of a note that these, I'm presenting my own slides, my own views, not necessarily representative of the ACR or the MPF specifically. So with that, I'll keep going here if I can get this slide. There we go. Okay. So just a broad overview of what we're talking about here today. So we're talking about treatment of the psoriatic arthritis patient. So in treating a patient with psoriatic arthritis, there's many things that we need to think about. And actually, you're going to see today that most of those things are not in the guidelines. The guidelines are really focused on how do we treat musculoskeletal disease and how do we treat psoriasis. But all these other very important things are not included there because there just isn't room to talk about all of these things. So I'm going to briefly mention them now. So one is, obviously we need to treat the psoriatic arthritis and the psoriasis, but we also need to manage the treatment burden and the kind of burden of dealing with these very expensive therapies sometimes. So specialty pharmacists are really important to helping us. Oops, I clicked the wrong button. In addition, let's see. So in addition, patients with psoriatic arthritis have a number of common concomitant conditions. So what I mean by that is that patients with psoriatic arthritis have a higher risk of diabetes, are more likely to be obese, have higher risk for cardiovascular disease, osteoporosis, inflammatory bowel disease than other patient populations. And skin cancer in patients with psoriasis in particular who've had a lot of light therapy, and some of our therapies may increase the risk for skin cancer as well. So all those things, we need some help from the primary care provider in screening for some of these and managing them. Additionally, psoriatic arthritis has a major impact on how you function at work and how you interact with family and friends. And so we don't talk about these enough, and I think these are things that we need help addressing sometimes. So sometimes psychiatry can help with this, or occupational therapy in terms of how to set up the work environment in a way that's friendliest for the patient with psoriatic arthritis. And along with these, of course, is emotional well-being. There's a high prevalence of depression and anxiety in patients with psoriasis and psoriatic arthritis. And unfortunately, we don't address that enough, and that's really important to address in treating the whole patient. Fatigue is very common in psoriatic arthritis in particular, sometimes in psoriasis as well. And along with that, sometimes disturbed sleep is part of the cause of the fatigue, and so we need to address those as well. And finally, regular physical activity, physical therapy, and kind of diet and being just generally healthy are really important for our patients as well. And sometimes it's harder to address those things, and so the patient kind of has to be a little proactive in any one of these things, bringing these up to their physician. So, like I said, we're going to focus today mainly on this musculoskeletal disease and then skin disease. So when I talk about musculoskeletal disease, I'm saying that patients with psoriatic arthritis have more than just arthritis. So when we think about rheumatoid arthritis, we primarily think about joint involvement. So this peripheral arthritis, swelling of the fingers and toes, for example, of the wrists and ankles. But that's only part of this disease. There's also enthesitis, which is inflammation where a tendon, ligament, or joint capsule inserts onto the bone. So the Achilles tendon, where it inserts onto the ankle bone, is a very common area of enthesitis. But there's entheses all throughout the body. And this helps differentiate psoriatic arthritis from rheumatoid arthritis. Dactylitis is swelling of an entire digit, a whole finger or whole toe, like a big sausage. Also very common in psoriatic arthritis. Patients with psoriatic arthritis sometimes get axial disease, or basically ankylosing spondylitis. So this is something that is just one of the features of psoriatic arthritis that happens in about 20% of patients with psoriatic arthritis. In addition, there's the skin psoriasis, the nail problems that go along with psoriasis, and then these comorbidities or concomitant conditions that I mentioned, like diabetes, depression, anxiety, and so on. So when we're thinking about choosing a therapy, the rheumatologist is really hopefully think about all of these different things when we're selecting the best therapy for the individual patient. As we move forward, I'll tell you that some of the guidelines are specific to one of these areas or another. I also mentioned these concomitant conditions. So inflammatory bowel disease is Crohn's or ulcerative colitis, and this is about 10% of patients with psoriatic arthritis will have inflammatory bowel disease. And some of our drugs make this worse, and some of the drugs just don't treat it. And some drugs may even precipitate it. And so we have to know about inflammatory bowel disease and ask about inflammatory bowel disease. Same with uveitis. Uveitis is inflammation in the eye, and that happens in about 5 to 10% of patients with psoriatic arthritis. And similar to inflammatory bowel disease, some of our therapies treat eye disease and some don't. So again, we need to know about that when we're selecting a therapy. So I've otherwise talked about the association with these. The other one I didn't mention is fatty liver disease, which is really common in psoriasis and psoriatic arthritis and has an impact on methotrexate use, which is a common drug. So basically what I'm saying here is that the physician needs to know about all these things in order to make the best treatment selection. So why do we make treatment guidelines? There's a few reasons. One is that there's so many new things happening all the time, particularly in psoriasis and psoriatic arthritis, and so many new drugs that it's really hard for the practicing rheumatologist or dermatologist to keep up with everything that's going on. So we want to make a succinct kind of summary of all the new evidence and show where the evidence points into how we should use our therapies. So the goal is to describe appropriate care based on scientific evidence and to help clinicians utilize available therapies. In addition, guidelines are also made to reduce inappropriate variation in care. So if there's some drug that shouldn't be used in psoriasis or psoriatic arthritis, we want to make a recommendation that it's not used so that so patients aren't going through that. And finally, recommendations are also useful, and then we highlight what we don't know. In the end, we make all these treatment guidelines to ultimately improve patient care. And this is particularly important for psoriatic arthritis because it's so complex and it's often just treated similarly to rheumatoid arthritis. So we want to make sure that physicians are not just treating psoriatic arthritis like rheumatoid arthritis and are using the evidence that we have to select the best therapy. So this is the publication. It just came out a couple months ago for the treatment guidelines of psoriatic arthritis. So I'm going to talk through a couple of the key recommendations in this paper. This paper is about 30 pages long, so I'm not going to go through all of it in detail. We'll just go through some of it. So I'm going to talk about the guideline process. Each treatment guideline has a different kind of process. This is a fairly standard process, but I'm just going to walk you through what we did. So first, we had a meeting in September of 2017 to decide what are the important questions. I'm sorry, September 2016. To make a list of important questions that needed to be addressed. What were the critical things that we wanted to make sure that clinicians have the answers to? Then we had to look into the evidence, and we had a group of people who were very skilled at evidence searches to help us find all the evidence for these individual questions that we came up with. And then we graded the level of evidence. So is it high level of evidence, moderate, low, or very low? Then we examined the harms and the benefits of each therapy, and we reviewed patient preferences. So we actually had a patient guideline panel that I'll talk about as well. And many of those patients were National Psoriasis Foundation members. And then finally, we made recommendations based on the evidence and kind of a summary of all of these different preferences. So every time we make a recommendation, we say, is it a strong recommendation or is it a conditional recommendation? So what does that mean? That means that patients, if it's a strong recommendation, most people in your situation would want that course of action. That course of action has great evidence, and it really should be done most of the time. A conditional recommendation means that there's not that great of evidence to tell you one way or another necessarily, but we believe that at least half of people would want the recommended course of action, but many might choose a different course. When we a conditional recommendation, we have to say all the reasons why choose not to go with that course of action. So in the recommendations, I will tell you that 96% of our recommendations are conditional. So we had very little data to make many strong recommendations. So almost all these recommendations I'm going to tell you about are conditional, meaning that while most people might go with this course of action, there are several reasons that people might choose a different course of action as well. So in our treatment guideline, we mostly focused on these blue therapies. So these are all the available immunosuppressive therapies. Some of them are actually not that immunosuppressive, but in any case, medications that we use to treat psoriatic arthritis over the long term. You probably know that we often use anti-inflammatory drugs like ibuprofen and naproxen, for example, and glucocorticoids are prednisone and methylprednisolone, and then steroid injections. But these are all really symptomatic treatments and not really good long-term plans. So in this guideline, we focus on the long-term plans. We also examined physical therapy, occupational therapy, smoking cessation, weight loss, massage therapy, and exercise to the best we could. These are the only non-pharmacologic therapies we included because we thought they were very important and thought that they may have evidence at least to say something about them. When we talk about whether a therapy is good or not, we have to have some benchmark. So in this particular case, we're using two different benchmarks. We're using the ACR20 primarily and MDA as well. So ACR20 means a 20% response in at least your swollen joint count, your tender joint count, and then 3 of these other 5 elements: patient global, patient pain. The health assessment questionnaire is a functional questionnaire, the physician global, and the C-reactive protein, a blood test. So this is the primary measure used in randomized controlled trials of psoriatic arthritis, and this is how drugs get approved. So that's why we decided to use this measure to define whether or not a medication was working or not. The other medication is called minimal disease activity. The other outcome is called minimal disease activity. And that just says that you have to have 5 of the following 7 elements: a swollen and tender joint count of less than one or less tender joints, 1 or less tender entheses, a low function score, meaning which is actually good. So you want to be doing really well in terms of patient-reported function, a low or very good patient global assessment of their disease, a patient pain assessment that's low, and then low amount of psoriasis. So you have to have 5 of these to get into this kind of low disease activity or state. So you'll see these come up as we talk through some of the guidelines. So I also mentioned that as a part of this process, we had a patient panel. So we asked them to do the exact same things we're going to ask the physicians to do. So first, we walked through 10 to 12 PICO questions with them, or these different questions in the evidence. And then we asked them to provide their considerations when selecting therapies. So how much did they weigh certain treatment burdens as associated with the different therapies, how well it worked, how fast it started to work, was it oral or IV or subcutaneous injections, and what were the known side effects and harms. And then we also asked them to weigh the unknowns, like how this drug performs in pregnancy or how safe it is in pregnancy. We also talked to patients about the impact of psoriasis versus the impact of the arthritis and how they would use that to choose a therapy. So we learned a lot from the patients, and that went into each of these different recommendations. So now I'm going to talk to you about some of the individual decisions we made. One thing is that there's no treatment pathway. So it doesn't tell you how to treat a patient from start to end. It just says that when you're in this particular situation, how do you choose between drug A and drug B? So there's just pairwise comparisons. So it only helps if you're trying to decide between two therapies or even a set of therapies in a way, it might tell you the best one. And because all of these are conditional, again, it means that the patient and the physician should discuss the risks and benefits for them as an individual patient. So these are some key highlights from the guideline. The biggest difference from previous guidelines is that we recommended that among patients with psoriatic arthritis, on average, the physician could start with a biologic as the first therapy over other oral therapies like methotrexate, for example. And this is a major shift in how psoriatic arthritis is treated, because in general, patients have been treated with methotrexate, luflanomide, or sulfasalazine first prior to moving on to a biologic therapy, and almost all insurance companies have always mandated that. But what we are saying in this particular guideline is that there is better evidence that the TNF inhibitors work faster and more effectively than these other oral therapies in general. Now, there's going to be many patients who are going to want to start with the oral therapy first without jumping right to a biologic. And I think that was one of the things that the patients brought up, is sometimes it's scary to kind of go to a big gun first. But most of them had said that having gone through these other therapies, they had side effects that kind of slowed down their life, whereas with the TNF inhibitors, they felt so much better, so much faster, that they had preferred the TNF inhibitors. So the patient panel and the physician panel came to the same decision at the end of the day. In addition, so we said that for patients with mild disease, however, if you just have a few joints, you don't have much psoriasis, then you would probably choose one of the oral therapies first, because it may be a milder drug and you might not need as much power as a TNF inhibitor has. There are also reasons that you might select one of the other newer therapies, like the IL-17 inhibitors, that's like secukinumab or Cosentyx, or ixekizumab or Taltz. And that's when some people have more severe psoriasis. And then you may select ustekinumab or Stelara if less frequent dosing is preferred. So there's a variety of different ifs, ands, or buts so for this particular recommendation, but it does change the way we think about treating psoriatic arthritis. In addition, there's a recommendation to use a treat to target strategy. I'm going to come back to that in 1 minute. And then we recommended weight loss in patients who are obese, and I'm going to show you why. And finally, smoking cessation, we noted, is really important in patients who smoke. This is because we already know that psoriasis and psoriatic arthritis are associated with heart disease, and we also know that smoking is associated with worse pain and worse outcomes. So this was one of the only strong recommendations, is that we know smoking is bad for all different kinds of reasons, and so people who are smoking should absolutely stop smoking, with help, of course. So I mentioned treat to target. So what is treat to target? The idea of treat to target is that we're seeing a patient on a regular basis and we're adjusting their therapy to get them to the place that they want to be. So the idea is that you come in for a first visit, you and the physician set a goal for where you want to be. So how well do you want to feel? What do you want to be able to do, for example? Then the physician assesses that, and you assess it too, and then you make a treatment plan. So often, this is a combination of patient-reported measures and physician-assessed measures. So like the patient-reported part would be your overall assessment of how you're doing, and your pain assessment, or even a questionnaire like the RAPID-3 if some of you do that in clinic. And then the physician assessment would be things like the tender and swollen joint count and the psoriasis and the enthesitis. So let's say you're at high disease activity, you get a treatment, 3 months later, you're doing a little bit better, but not a lot better. Maybe you consider adding therapy to that. So maybe now you're on a biologic therapy and an oral therapy. And then 6 months, the 6-month follow-up, you're doing even better. And so you continue that therapy, and you meet your target at 9 months. So the main idea of treat to target is that you reassess an objective measure like a questionnaire or swollen and tender joint count at each visit until the goal is reached. Sometimes the goal changes. Sometimes you realize you might not get to remission, and so having a low level of disease activity and a high level of function is what you really want. Physical therapy might play into this as well. So there's a variety of ways of doing this, but what we meant is that you are following regularly and objectively measuring the disease along the way. In my clinic, we use Rapid 3 so that patients are filling out a questionnaire before they come in, and then we can kind of see how that changes over time. So one of the things that patients brought up is this is kind of expensive because they have to come in more often, pay more copays. You have more copays for medications, for example, and you also may have more side effects from having more combinations of therapies. And so that's why it's a conditional recommendation. So for some people, this may not be worthwhile, but overall, it's generally recommended. All right, and then the next thing was weight loss I mentioned. So why is this important? Well, this was a study in which patients were starting a TNF inhibitor, like an Enbrel, Humira, Cimzia, Symphony, or Remicade. So they were starting one of those therapies, and they randomized patients to one of two diets. And it turned, this is just about over time who's going to achieve remission in those people starting the therapy. And you can see that if you were obese, you got to this better place faster, not obese. So these are the patients of normal weight with a body mass index less than 30. On the other hand, if you're obese, most people never reached low disease activity, or this MDA, minimal disease activity. So what we realize is that having obesity has a major impact on the likelihood of achieving remission with with therapy. Additionally, in this same situation, they randomized patients to one of two diets, so that it was among patients initiating therapy, different time points actually. So the study came first, and then this study. They were starting therapy, and they randomized them to either a Mediterranean diet or a low-calorie diet. And what they found is that among patients who got to neither diet worked better than the other, but what did come out is that if you lost 5 to 10% of your body weight, you were 3.7 times more likely to achieve remission or low disease activity. And if you lost more than 10% of your body weight, you were 6.67 times more likely to achieve low disease activity or remission. So even with just 5 to 10% of your body weight, which of course is, quite a bit still, it has a substantial impact. So this is almost a better impact than some of our therapies. So weight loss is incredibly important in psoriatic arthritis and psoriasis as well. Let's see. All right, this is the kind of final point from the guidelines, and then we'll kind of open it up for questions. One of the unique contributions of this guideline is a definition of what it means to have severe psoriasis or severe psoriatic arthritis. So there's been a number of definitions of severe psoriasis over here on the right in the past. Some have defined it by this psoriasis area and severity index. So this takes into account how much psoriasis you have and how red, thick, and scaly it is. And so there's this score of 12 or more, which is a pretty good amount of psoriasis. And then some people have said as a body surface area of 5 to 10% or more, so that's 5 to 10 palms of psoriasis on your body. But in addition to that, we kind of added to this and said that severe psoriasis has significant involvement in specific areas. So for example, hands and feet can be really tough areas to have psoriasis on, really bad nail disease. If it's under the breasts or under the armpits, that can be really painful. The scalp sometimes, and in the genital areas, of course. And then severe psoriasis can also be any psoriasis that has a major impact on the physical or mental functioning. So we kind of broadened that definition a little bit. And similarly with psoriatic arthritis, there's actually never been a definition for severe disease. So in this case, we said that severe psoriatic arthritis has erosions on the x-rays, high markers of inflammation, long-term damage that interferes with function, such as joint deformities of the hands or feet, for example. And by the way, the elevated markers of inflammation, this is only if you think it's from the psoriatic arthritis. There's a lot of reasons for it to be elevated, including obesity. High active disease that causes a major impairment in quality of life. So if you're someone who's a violinist and it's affecting one or two of your fingers, it has a major impact on your function. So that would be called severe psoriatic arthritis. If it's active at many sites and you have dactylitis and enthesitis, function limiting in a few sites, the violinist, or rapidly progressive disease. So we came up with these broad definitions to help clinicians get approval for the drugs that would typically be kind of more restricted, so that we can give that latitude to get patients better faster. Okay, so and the last thing I wanted to mention is these are psoriatic arthritis treatment guidelines designed for clinicians. But I also wanted to show that there is a patient guidelines at Creaky Joints. So Creaky Joints is another patient organization. They have a lot of these cool resources for patients, and there's the psoriatic arthritis guidelines. So this came out in September 2017 before we published these guidelines, obviously. So it doesn't have the thing about the TNF inhibitor first, but it has a lot of good information on your therapies and different exercise, all that kind of stuff. So similar things you can get on NPF, but some different things. This is an 80-page book, a PDF book that you can download once you kind of put your email in. So with that, I will turn it over to Bev to talk more about the NPF resources.
Great, thanks, Dr. Ogdie. We appreciate your insights about the new psoriatic arthritis treatment guidelines. You shared a lot of great information that will mean a lot to our listeners. We'll now move forward with the Q&A portion, and I will share resources after our Q&A. So we do have some questions that were brought in early on, as well as prior to our presentation today. So we'll just jump right in. Dr. Ogdie, the first question is, does the treatment for psoriasis always help with psoriatic arthritis?
That's a great question. So not necessarily. There are some therapies that are more effective for the skin than they are for the joints. And so it depends a little bit. So many times the biologic therapy is going to cover the psoriatic arthritis, but not always. And certainly phototherapy, for example, or topical therapies for the skin, that's not really going to help the arthritis.
Okay, great. Here's another one. What's the prognosis for someone with psoriatic arthritis that affects the hands, wrist, and has major joint pain?
So prognosis varies from person to person. So it's really hard to say. So people that have joint deformities, obviously we can't fix those once they happen. And additionally, patients can often have osteoarthritis. So it's hard, as people get older, people get osteoarthritis anyway. And your psoriatic arthritis joints may be more likely to have osteoarthritis. Not always, but sometimes. And so sometimes then it's hard to separate out what's active inflammation and what's damage related to osteoarthritis. So there's a lot of questions there in terms of prognosis, but if you have any of those elements that are associated with the severe disease, like high inflammatory markers and lots of joints involved with swelling, those are going to be the things that are going to be more likely to be more destructive, and so probably warrant more aggressive therapy.
Okay, thank you. That's good advice. Is it possible to reverse or stabilize psoriatic arthritis after 30 years of damage from the progression of the disease? You kind of answered some of it already, but
yeah. So once the damage is done, we can't reverse it. But the good news is that today we don't have as much damage in general moving forward. But yes, if you were diagnosed 30 years ago, you may have a lot of damage. So unfortunately, we can't reverse that, but hopefully we can still manage symptoms.
Okay, and here's a question about fatigue. I rarely have pain, some enthesitis. I suffer from debilitating fatigue. Are doctors starting to address fatigue more often? Some doctors don't even recognize it as a symptom of psoriatic arthritis.
You're right. So fatigue is a really big deal, and it's important for physicians to help deal with that. One of the hard parts about fatigue is that it's often multifactorial. So it could be related to sleep. It can be related to the disease, and we know that. It gets better in most patients once you treat the disease. But there are some patients where it doesn't get better, and in those patients, we have to kind of investigate what are the other causes. Is it that there's a sleep disturbance? Sometimes depression can be associated with fatigue. Fibromyalgia is very common in patients with psoriatic arthritis. About 20 to 30% of patients probably have fibromyalgia or some component of that, and that is often associated with pretty significant fatigue. So we have to sort out, does the patient have fibromyalgia? And in that case, we would manage the fibromyalgia a little bit differently. And then finally, exercise is so important. So good sleep and exercise, and hopefully we're telling our patients about that. But exercise is one of the best known therapies for fatigue. So we try to get people moving as much as possible, even though it hurts. But as you get going, it gets better, and so does the fatigue eventually too.
Terrific. That's great advice. What about diagnostic tests for psoriatic arthritis? Someone has emphysized sporadically, and that affects the upper back and neck and side with hip pain.
Great question. So diagnosis is sometimes challenging. So it's easiest when there's swelling of a joint. If there's not swelling of a joint, it becomes very difficult because you really need to document that there's inflammation somewhere. Now, I heard, so first of all, I think this is an exciting time for diagnosis. The NPF is investing a lot of money in developing a diagnostic test for psoriatic arthritis. And there's a big grant process out right now to have investigators submit grants to figure out how to do that. But aside from that, in this question, I heard side of the hip, back of the neck, and shoulders. And so whenever I hear that, I think a little bit about fibromyalgia or kind of the general mechanical pain. So that may not be related to the psoriatic arthritis, and it is harder to diagnose. So just trochanteric bursitis or pain on the outside of the hip is very common among lots of people. And that gets better with physical therapy a lot of times. It can be related to psoriatic arthritis, but is more commonly mechanical and better with physical therapy. The back and shoulders, that upper back, that tends not to be related to psoriatic arthritis either. It can be, but sometimes it's not. So again, I often prescribe physical therapy first, just when we're not able to sort it out, and if it gets better with physical therapy, a good course of physical therapy, then we might do some more investigation with imaging.
Okay, terrific. Here's one that has to do with pregnancy. They'd like to ask, what's the ideal timing for a patient with PSA to attempt conception? Is it safe for a patient to attempt while having active disease, and what can typically be expected with pregnancy? And are there any guidelines or recommendations that approach both pregnancy and psoriatic arthritis?
Those are really excellent questions, and a lot of people ask those. So I'll address the last part first. The ACR is working on a pregnancy guideline that would go across the different diseases because this is such a tricky issue sometimes. So I think that we can expect that in the next year or so, and hopefully that will be published soon. The second piece, though, the bigger piece, is when is it good to have, when is the best time to have a child? And there is no best time, as many people say, for all the kinds of other reasons. Ideally, you would like to have your disease in a good place and not so active. But sometimes that's not always easy. So there's a couple of things to think about there. There are some therapies that are thought to be safe in pregnancy. Sulfasalazine, for example, is frequently used in the setting of pregnancy. Low-dose prednisone sometimes. And then obviously prednisone has problems, though, because you can have gestational diabetes or other issues with it. But there's also medications like Plaquenil. It can sometimes flare the psoriasis, but can be safely used through pregnancy in general. And then the TNF inhibitors like Enbrel, Humira, Cimzia. In fact, Cimzia now has it in their label that it's safe for pregnancy. So we have monitored patients on TNF inhibitors. It's still tough because we don't have any, perfect evidence that it's not going to cause any harm, but it seems overall that it's not causing harm. So it's okay to get pregnant on those medications, although always have a conversation with your doctor before you do that because you want to have a plan regardless. So there's a lot to think about, but I would say don't let psoriatic arthritis prevent you from having a baby or trying for it. Do recognize that anti-inflammatories like ibuprofen, and those will prevent you from getting pregnant around the time that you're taking them because they can prevent the eggs from attaching to the wall. So it's fine when you're not trying, but you might want to hold those for a few days around the time you're supposed to be ovulating.
Okay, that's great information. I'm going to switch now to a couple questions about treatment. And the first is, does Medicare cover Cosentyx?
Unfortunately, Medicare does not cover the injectable drugs, period. So that includes Enbrel, Humira, Cosentyx, Taltz, all these medications. And in addition, unfortunately, patients on Medicare are not eligible for those drug programs that people with private insurance are eligible for. Sometimes supplemental insurance will help with that, but until we have biosimilars, I'm not sure that it's really hard to get Medicare patients access to the injectable drugs. Sometimes we use the IV formulations instead because we can get those. Or sometimes if you get to a physician's office, you're in a dermatology office, for example, that gives ustekinumab or Stelara, they can charge it through Medicare too. But it's really tough.
Okay. Another question, this individual's been on the same biologic for almost 12 years. How do they know when it's time to try something new?
Well, the good news is if you're on the same medication for a long time, it's probably going okay. And as long as you're feeling well and there's no major flares. So you know when you start to notice that the drug isn't working as well just before the next injection. So let's say you're taking the injection every 2 weeks, and at 8 to 9 days, you start to notice that you're having more stiffness, and then by day 12 or 14, you're noticing that you have a lot of stiffness and you have a little bit more of swelling, for example. That would suggest that the drug is starting to not work as well. So it's kind of little things like watching your disease activity overall. On the other hand, if you're perfect and you've been doing extraordinarily well for a long period of time, even a couple years, sometimes we think about pulling off the biologic to see how people do. There's always risk to that because people can flare. And sometimes when you go back to the same drug, it doesn't work as well. So that's, again, something you have to discuss with your physician.
Okay, and one more question. Do the recommendations address use of supplements?
They don't, because there's so little evidence about supplements, and not that they don't work, it's just that we don't have any evidence. People haven't studied them that well in psoriatic arthritis. So in general, it's something I talk to my patients a lot about, and I think that some people find benefit from certain supplements. There's also a lot of people selling expensive supplements that don't have any evidence at all, so I would be careful of that. But overall, no, they're not addressed because of lack of evidence.
Okay, terrific. Well, we will go ahead and answer some of the other questions that have come in through our Patient Navigation Center. We'll try to get back to you here shortly. So Dr. Ogdie, thank you for addressing all the questions that came in and for sharing your expertise with us.
Thank you for having me.
Sure. Okay, I'd like to say a few minutes about one of the resources through the National Psoriasis Foundation. It's our Chronic Pain Management Hub. You can actually receive a free pain management guide and tracker booklet through the hub. Here's the email the address that you can access that information. There are also tips for talking with your healthcare provider about managing pain and chronic pain. You can also chat with our Patient Navigation Center by phone, email, live chat, or Skype. Once you leave today's webinar, you'll receive a survey, so please provide feedback about the presentation. Tell us what you think. We value and appreciate your comments. I'd also like to thank our sponsors, AbbVie and Amgen, once again for supporting today's webinar about the new psoriatic arthritis treatment guidelines. And finally, I'd like to mention you can access our complete webcast archive by visiting psoriasis.org/webcast. This concludes our presentation today. Thank you for attending.